If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we're looking at the new updated NICE guideline on type 2 diabetes in adults, always focusing on what is relevant in primary care only. The diabetes guideline is a comprehensive document, so I'm breaking it down into clear and practical sections. Today we're focusing on how to introduce medicines, how to review them, and what to do when further treatment is needed after initial treatment. In recent episodes we covered the earlier sections of the guideline. In a future episode we will move on to insulin-based treatment in more detail and the management of complication. Right, let's jump into it. First, let's look at introducing medicines. We should introduce medicines one at a time and check in tolerability and effectiveness before moving on. When starting initial therapy with modified release metformin and other medicines, we should begin with metformin and confirm it is tolerated. If we're using an SGLT2 inhibitor, we should start it once metformin is at the maximum tolerated dose. If we're also planning to use a GLP-1 receptor agonist or tirzepatide, we should introduce this once the SGLT2 inhibitor is at the maximum tolerated dose. So even though the initial plan may involve more than one medicine, we still introduce them sequentially, one at a time, and monitor them carefully. Now let's look at preventing diabetic ketoacidosis with SGLT2 inhibitors. Before starting an SGLT2 inhibitor, we should assess the risk of DKA. Risk factors include a previous episode of DKA, acute illness, dehydration, or following a very low carbohydrate or ketogenic diet. We should assess modifiable risk factors before starting treatment. For example, if someone is on a ketogenic diet, we may need to delay the SGLT2 inhibitor until the diet changes. We should also advise people that a very low carbohydrate diet increases the risk of DKA while on an SGLT2 inhibitor. They should speak to a healthcare professional before starting such a diet, and treatment may need to be temporarily suspended. Next, let's look at general principles when reviewing treatment. Before switching or adding medicines, we should optimize the current regimen. That means checking doses, adherence, side effects, and revisiting lifestyle advice. Now let's look at reviewing metformin. If someone is already taking standard release metformin, we can continue it. If it is not tolerated, or if the person prefers, we could switch to modified release metformin. Now let's look at reviewing other medicines. If a person has reached their target, we should consider continuing the medicines that contributed to their success. We should consider continuing SGLT2 inhibitors for their cardiovascular or renal benefits, even if HbA1c targets are not fully achieved. We should stop GLP-1 receptor agonists or tirzepatide if the person becomes underweight with a BMI below 18.5. We should also stop them if they're not helping the person reach glycemic targets, if they're not being taken for cardiovascular benefit. We must take into account adverse effects from combinations such as hypoglycemia, and we should not combine a GLP-1 receptor agonist or tirzepatide with a DPP-4 inhibitor. Now let's move on to further medication group by group. In a previous episode we covered initial management, also group by group. So if you need a refresher for each of these groups, please refer to the corresponding episode on this channel. For further medication, for people with no relevant comorbidity who need further treatment, we should add a DPP-4 inhibitor. If this is contraindicated, not tolerated or not effective, we should add a sulfonylurea, pioglitazone or insulin-based treatment. For people with heart failure who need further treatment, we should also add a DPP-4 inhibitor. If that is not suitable or not effective, we should add a sulfonylurea or insulin-based treatment, bearing in mind that pioglitazone is contraindicated in heart failure. For people with atherosclerotic cardiovascular disease who develop this after initial treatment, we should add subcutaneous semaglutide up to 1 mg once a week for cardiovascular and renal benefit. If further glycemic control is needed, we should add a sulfonylurea, pioglitazone, or insulin-based treatment. For people with early onset type 2 diabetes who need further treatment, we should consider adding a GLP-1 receptor agonist or tirzepatide. If these are not suitable, we should add a DPP-4 inhibitor. If that is also not suitable or not effective, we should add a sulfonylurea, pioglitazone, or insulin-based treatment. If they are already taking a GLP-1 receptor agonist or tirzepatide and still need further control, we should add a sulfonylurea, pioglitazone, or insulin. For people living with obesity, if weight management is a key issue, we should follow the obesity guidance. If after at least 3 months of initial therapy, further glycemic control is needed and are not already on a GLP-1 receptor agonist or tirzepatide, we should consider adding one. If these are contraindicated, not tolerated, or ineffective, we should add a DPP-4 inhibitor. If that is not suitable, we should add a sulfonylurea, pioglitazone, or insulin. If they are already on a GLP-1 receptor agonist or tirzepatide and still need further control, we should add a sulfonylurea, pioglitazone, or insulin. For people with chronic kidney disease who need further treatment, we should consider adding a DPP-4 inhibitor. If they are already on one, or it is not suitable, we should consider adding pioglitazone or a sulfonylurea if eGFR is above 30, or insulin. Finally, for people with frailty who need further treatment to control symptoms and reach targets, we should consider adding a DPP-4 inhibitor. If they are already on one, or it is not suitable, we should consider adding pioglitazone, sulfonylurea, or insulin. When choosing drugs in frailty, we must remember that sulfonylureas and insulin increase the risk of hypoglycemia and falls. So that is it, a review of a section of the NICE guideline on type 2 diabetes. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guideline. You must always use your clinical judgment. Thank you for listening, and goodbye.